I'm Sydney Rice. I'm a developmental behavioral pediatrician, and I spend all of my clinical time caring for children with disabilities. I work on several different interdisciplinary teams, and I'm the program director for the University of Arizona LEND, which is a training program for professionals from 14 different disciplines. We work together as an interdisciplinary faculty and interdisciplinary trainees to learn from each other. Clinically, I work on one team that has 10 different professionals, and together we see 6 to 7 children in a half-day clinic. That's a lot of professionals for that many children. But I think of us as the blind men or women feeling different parts of the elephant. We share very different perspectives, but we learn from each other and value each other's contributions. As physicians, we are often presented with situations that we really cannot solve alone. For example, I was recently in a clinic in which we needed to encourage a young girl to start catheterizing. She was terrified of this, and she wanted her mother to keep catheterizing her for the rest of her life. Starting catheterizing had been recommended multiple times, and each time the girl refused. The family gave up, but we were increasingly concerned about her privacy and her vulnerability if she was planning to have someone else catheterize her 5 times a day. We knew her mother might not always be available. So we drew on the team. The urologist helped us find catheters that might be easier for her to use. The psychologist and I talked about options for how to help her calm down. And I spoke with the pharmacist about short-acting medications that we might use. The nurse trained her to catheterize, and the child life specialist had a pet therapist there to help her with relaxation. The educator worked with the school to make sure accommodations were in place so that she would have longer breaks to catheterize. And I spoke with her pediatrician, the school nurse, and the school psychologist to let them know what we were doing. The social worker helped connect both the girl and her mother with community resources, and she introduced the girl to a group of teens with similar medical issues. I'm sure I've left somebody out of this, but the fun for me was seeing all of this come together that we could not do alone.
Hi, my name is Dr. Elaine Jones. I'm a teacher and a researcher from the University of Arizona at the College of Nursing. My research focuses on health education for deaf adults. We have health classes that are specifically focused for deaf adults. And these are people who have some risk for heart disease. The name of the program is Signs of Health, or SOHI. The classes meet 2 hours a week for 12 weeks. And the teacher is a deaf man named Mike. He's a fabulous teacher, has a lot of experience with teaching, so he's wonderful. And now you can see that my sign is a little bit limited, so now I'm going to use my voice only. I work with people from other professions in my research. For example, the team that I have now is myself, a sign language interpreter, Amy Druick. She does data collection, is very fluent in both spoken English and sign. The teacher, as I said, is Mike Crago, who is very experienced in sign language and a fabulous teacher. I have a collaborator named Dr. Lisa Staton, who's from public health, and a physician, Dr. Stephen Barnett from Rochester, who helps us with data and safety monitoring. It's a wonderful team. Thank you and goodbye.
My name is Ann Ryan. I'm an attorney in the Department of Family and Community Medicine and director of the Tucson Family Advocacy Program. I provide free legal services to low-income patients in areas affecting patient health, including disability benefits and access to health care services. I also teach resident and faculty physicians how to become more effective advocates so they can better help their patients obtain the services they need and are entitled to receive. Collaborations between healthcare providers and lawyers are essential in my work with disabled patients. Imagine you're a physician and your patient has progressive weakening of the extremities with impaired balance. You prescribe a 4-wheeled walker to help her ambulate safely and independently, but the insurance company denies your request for authorization. What can you do? In addition to referring the patient for legal help, the physician can provide invaluable support in an appeal of this denial. The patient's ability to ultimately receive the prescribed medical equipment will be greatly improved if the physician can help the lawyer understand the underlying medical conditions and why the prescribed equipment or services are medically necessary.
Hello, I'm a doctor of pharmacy and pharmacotherapy specialist in geriatrics and chronic disease management. I work with older adults, including those with disabilities, in clinics and patients' homes. I live interprofessional education and practice because all of my clinical practice is done within interprofessional teams, and I teach interprofessionally in my geriatrics course, which is offered to interprofessional students. Collaboration among health professionals in teams is an absolute must in caring for older patients with disabilities. We know that medications improve patients' health and quality of life, but multiple factors influence proper medication taking process. For example, imagine you have an elderly patient who receives 29 medications for his multiple comorbidities. He is legally blind with hearing impairment and walks with a walker or pushes his wife's wheelchair. He has a very busy schedule keeping up with both his and his wife's medical appointments, as he is the primary caretaker for his wife who has Alzheimer's disease. He is a veteran with intelligence and dignity who fiercely fights to remain independent. How would you manage his medications and health? Well, this was my patient, or actually our patient, since I was fortunate to be working with the geriatric team. I reviewed his medication regimen and eliminated unnecessary duplicate or interacting medications and replaced some with safer agents. The geriatrician and I worked together to manage his chronic conditions. The patient and I worked to tailor his medication regimen to fit his daily routine and used pill boxes to ensure adherence. The occupational therapist provided the reader that enlarges printed information, including prescription labels, and a hearing amplifier we can use during clinic visits. The ophthalmologist provided special glasses to wear when he's not at home to use the reader. The social worker referred the patient to VA Blind Rehab Program, where he learned to use a computer and various independent living skills. The physical therapist worked with him on strength and balance. The psychologist counseled him for depression and caregiver burden. The home care nurse visited the patient's home to monitor his conditions. Clearly, this was a team effort, and the patient and his wife remained independent until his last days.